So our first speaker. So today we start again with what's new in my specialty. The first speaker we have this morning will be Dr. Stephen Brown. We appreciate Tanner Clinic's support for that. I've been suggested that all of those from Tanner Clinic please stand up so we can recognize you. Thank you very much. Thank you to Tanner Clinic. We appreciate Tanner Clinic, and we'll turn the time over to our first What's New in My Specialty, Dr. Stephen Brown.
Thank you for coming again. Good morning, everyone. It's nice to be back this year again, and I was just thinking, despite my efforts last year, I got the invitation to come back and speak with you again. I don't know if that's because I did such a good job or because there was lack of other people to do this, but I'm here, so I'll let you be the judge on that. As I got this topic, it was very difficult to figure out what I wanted to speak about and what would help you in terms of your education today. It's a very broad topic, and we only have about 20-25 minutes, so I'll go pretty quick through some of these topics. I don't have any financial disclosures today, and today we're going to talk about a few different topics. The latest guidelines for management of osteoporosis. I'd like to also talk about some of the advances in diabetes medicine in terms of medical management, and also a lot of the technology that can be very confusing to navigate through. And then probably the hottest topic in endocrinology right now is obesity medicine and some of the medications that have kind of risen to the top of our list with a lot of the social media things that have come out lately with these medications. So we'll talk about that. Osteoporosis, I feel like, is a misunderstood topic in endocrinology. It's one that I see a lot of confusion about from primary care doctors of when do we treat, when do we not treat. And so I wanted to go over some of the ACE guidelines that are there to help us with this. So who do we screen, first of all? Any postmenopausal woman over the age of 50 years old should be screened with a DEXA scan. Others that have a high fracture risk also should be screened. Those people can include those who have connective tissue disorders. It can be someone who's on chronic corticosteroids. Make sure you get a DEXA scan on those people to see how their bone health is doing. We do order a DEXA scan, and diagnosis of osteoporosis is going to be a T-score of less than -2.5, or they can also be in the osteopenia category, which is -1.0 to -2.5 with a high FRAX score. Also, if they've had any type of fragility fracture, that automatically puts them into the category of osteoporosis despite having a normal bone density even. Once you get that diagnosis back, it's very important to do a secondary evaluation of potential causes that could cause osteoporosis. I think we just lost the slides here. Some of those secondary evaluations can include getting just a normal CBC, also a CMP to check their electrolytes, their phosphorus level, magnesium levels, as well as a vitamin D level. So vitamin D is important for bone health. Other things that we like to evaluate for would be a parathyroid hormone level. I see a lot of hyperparathyroidism. For some reason, it's becoming more and more prevalent in our society. We're not sure why that is, but that's one of the major hormonal causes of osteoporosis. Other tests to go ahead and get would be a urine calcium level. You can have both malabsorption syndromes from like a bariatric surgery that can cause low calcium absorption as well as low vitamin D absorption, as well as you can have hypercalciuria, which also can contribute to bone density issues. There's also, we like to check thyroid testing. Thyroid testing in terms of hyperthyroidism can cause osteoporosis, and we like to treat that, which can also help bone density. Diseases such as celiac disease also cause malabsorption, and those patients are at very high risk for osteoporosis. A few other things that you can check for: multiple myeloma and get an SPEP on these patients. I've caught several of those cases as part of my diagnosis process for osteoporosis. And a rare disease, Cushing's disease, I actually caught one Cushing's patient she got referred to me for osteoporosis, had extreme worsening of her bone density over a 3-year period of time. And because of that, I got a urine cortisol, and sure enough, she had Cushing's disease. We treated the Cushing's. She's doing great right now in terms of both her Cushing's disease and her osteoporosis. And oftentimes, if you correct the hormonal abnormality, it will actually improve the bone density without any further treatment there. So osteoporosis treatment, once you've had the diagnosis, it's recommended to do a vitamin D supplement, approximately 1,000 to 2,000 IU daily, a calcium supplement or a calcium intake on a daily basis of approximately 1,200 milligrams daily, reduce alcohol intake to less than 2 drinks a day. As always, stop smoking. And since we're here at a lifestyle conference, weight-bearing activity is very, very important in helping bone density. A lot of our patients have adopted sedentary lifestyles that just contributes to osteoporosis, and getting them stronger will help their muscles strengthen their muscles and allow them not to fall as much, because mostly falls are what is causing the fractures that we see. Fall precautions such as installing handrails in their homes, having them remove any loose furniture or rugs that they could slip on. If you're in my house, there's plenty of toys to slip on all over my house for my kids. Most of our elderly patients don't have that problem. And then pharmacological therapy, deciding which medication to use in which situation is important. So the question is, when do we start pharmacological therapy in these patients? If they are considered a high risk, and this is the definition of this is osteopenia with a high FRAX score, or if they've had a fragility fracture, then that would place them in the high risk category. That's a major osteoporotic fracture risk of greater than 20%, and this will be given to you on your DEXA scan report, or a hip fracture risk of greater than 3%. Also, a T-score of less than negative 2.5 would put them in that category. Medications that we often use in this category are bisphosphonates that can include alendronate, risedronate, zoledronic acid is a little more potent form, IV route, and then also denosumab, which is the every 6-month injection. In terms of our very high fracture risk patients, these patients are those who have had a recent fragility fracture, or they have multiple fractures. They can be those who are on chronic corticosteroids, or they are those who have fractured while they are on current therapy with the other medications we just talked about. Also, if they have a T-score less than negative 3.0, or a FRAX score for total fracture risk of greater than 30%, or a hip fracture risk of 4.5%, that puts them in the high risk category. And these are the patients we really should be more aggressive with in terms of reducing or improving their bone density. So medications that we often use here, abaloparatide, denosumab, romosozumab, which is a fairly new medication, teriparatide, and then zoledronic acid. Typically, the oral bisphosphonates do not treat these patients as well as these other more potent medications. And this is a table from the endocrine practice guidelines for osteoporosis. As you can kind of see here, the vertebral fracture, you're not going to really go wrong with improving their fracture risk for vertebral sites with any of those medications that we just talked about. In terms of non-vertebral fractures, so your abaloparatide and also alendronate work well, denosumab, risedronate, and then teriparatide and zoledronic acid will help with those. The problems with these other medications is that the studies were just not powered for hip fractures, and so the data does not support that, although likely they're going to help out. We're going to move on to diabetes. So if I can do anything to impress on your minds today, diabetes is a huge problem and is going to continue to be a huge problem as we go forward. Epidemiology-wise, there are about, in 2021, 541 million adults in the world who had diabetes, 537 million diabetes patients in the world, and there's lots more that are probably undiagnosed with this disease. That is if my math's right, this early in the morning, 1 billion people in the world suffer from diabetes or prediabetes. That is a lot of people. In 2030, projection is 643 million adults in the world, and 2045 up to 784 million people with diabetes. Type 1 diabetes, every year 350,000 people get diagnosed from the age of 0 to 19 with type 1 diabetes. It is costing our healthcare system almost $1 trillion a year for management of diabetes. Due to this, and about a year ago at this time, the World Health Assembly in Geneva, Switzerland came up with a few goals for diabetes care. Those include trying to get 80% of individuals diagnosed with diabetes to have good glycemic targets. That's typically at least an A1C below 8%, often down to 6.5%, and good blood pressure control. So they want 60% of people who are over 40 years old with diabetes to be on a statin, and 100% of type 1 diabetes to get affordable insulin and glucose monitoring devices. This is something that has been worked on quite a bit over the past couple years. We're still not there on that last goal, but I think we're getting closer and closer. And if I can throw out a plug for diabetes education, please, please, please educate your patients. If you diagnose them with diabetes for the first time, they need education. This is something our society does not understand. These patients struggle. They don't know what carbohydrates are. I often get patients come in and say, yeah, I don't eat any sugars, I don't eat any cakes, I gave up soda. And then I ask them how they're doing with carbohydrates. Oh, I don't eat anything. I just eat a lot of breads and pastas and rice and cereal. I say, well, there's our problem. So please, please take some time with your patients. I know you have busy schedules, busy practices, but this is something that we really need to do as healthcare providers to provide that education. Refer them to a dietitian. Every person who gets a diagnosis of diabetes should go see a dietitian and have that education. It will go such a long ways. So type 1 diabetes, I don't know if you knew this, but there are 3 stages of type 1 diabetes. And this is something that has been more of a recent development in endocrinology. Stage 1 includes having autoimmunity, so they have positive antibodies. You're thinking to yourself, how are we going to figure out people who have autoimmunity, because we don't screen everybody for these antibodies. So if they have a first-degree relative, often they can get screened for this to see if they're at risk for type 1 diabetes. These patients have normal blood sugars. They're asymptomatic. They just have the positive antibodies. Stage 2 is the same thing, except they start getting sugars into the pre-diabetes range. So that can include fasting blood sugars in the 100 to 125 range. A1Cs are now abnormal, 5.7 to 6.4, but still have not developed any symptoms of diabetes. Stage 3 is when they become diabetic. They have the autoimmunity, the antibodies against their pancreas. They have hyperglycemia at this point and meet the criteria for diabetes, and they also become symptomatic and often end up in a hospital setting. The reason this is important is because we can now prevent and delay, I shouldn't say prevent, can delay the progression of type 1 diabetes. So about 100 years ago, insulin was discovered. There has not been a single advance in type 1 diabetes since that date until now. We have definitely improved our insulins, better short-acting and fast-acting insulin, but nothing like the discovery of insulin has happened for over 100 years in type 1 diabetes care. Now there's a medication called DipIBLM. It was recently FDA approved last year to delay the onset of stage 3 type 1 diabetes. Its mechanism of action is a monoclonal antibody against the CD3 cells or CD3 sites on T cells, and it basically prevents the destruction of the beta cells in the pancreas. The trial that got this FDA approved was a phase 2 randomized placebo-controlled trial. They took relatives of patients who have established type 1 diabetes who were at high risk for development of diabetes and screened them with the antibodies to see if they were positive or not. The treatment group included a single to 14-day course of teplizumab or a placebo, and the follow-up and results were progression to clinical type 1 diabetes, which was evaluated using an oral glucose tolerance test at 6-month intervals. And really fascinating results came from this trial, where you can see the the graph shows a proportion free of type 1 diabetes and then the bottom axis is the duration of time. You can see after less than 6 months, there was a significant separation in the two groups. And you can see there's quite astounding results from this trial. The actual results showed a median time of 48 months versus 24 months in favor of the teplizumab group. In terms of progression to stage 3 type 1 diabetes, it still does not stop this from happening. It just delays the progression. 43% of the group on the medication still progressed to type 1 diabetes. 72% in the placebo group, and that was about 15% year of diagnostic rates in the treatment group. The important part of this trial, you think, oh, what does it matter if we delay for 2 years? 2 years is a long time to live without diabetes. It helps these patients have a little bit better quality of life. They don't have to be as strict with glucose control, so it gives them 2 years without being on insulin. A few technology updates. So from this slide, the main message is if anyone's on insulin, put them on a continuous glucose monitor. Try to get that approved for them. Just putting on a continuous glucose monitor often lowers an A1C of about 1% by doing nothing else besides putting them on that monitor. There's a lot of confusion, I think, about what the types of continuous glucose monitors are. There's three different categories. There's real-time CGM. Real-time CGM gives you a continuous feed of glucose to either your phone device or the reader device. Intermittent scanning CGMs are those devices who you actually have to scan the sensor. And then there's also the professional CGMs, which can be used in our office, which blinds the patient to their glucose values, but allows us to download it later to see kind of patterns. And this allows them to have kind of the same normal life, not change anything, and then we can establish where their patterns are. Some examples of real-time CGMs are the Dexcom 6 and 7. Freestyle Libre 3 has recently come out, and Medtronic Guardian 3 and now Guardian 4. And then there's also a very new sensor that I learned about not too long ago is the Eversense E3 sensor. It's the first FDA-approved implantable sensor that can be there for about 6 months. The intermittent scanning glucose, continuous glucose monitor is a Freestyle Libre 2 still. This is a slide that I came up with to kind of help figure out when you're prescribing a sensor, and sometimes if you're into the pump area of diabetes medicine, to figure out what sensor can pair with pumps. The Dexcom sensors basically pair with both the tandem pumps and also the Omnipod 5. Right now, the G7 has been approved for pump therapy, but it is not integrated yet. So if you do have a pump patient on either the tandem or the Omnipod 5 pump, do not switch them over to G7 because you'll lose that feature right now. Libre 2 is not compatible with any pumps right now. Libre 3 will be, but again, it has been FDA approved. And also Freestyle Libre 2 has been FDA approved to be compatible with the pump, but they're not integrated yet. Medtronic Guardian 3 and 4 only work with the Medtronic pumps that are coming out, and the Eversense sensor is not FDA approved or compatible with any of our pumps at this time. A couple of pearls to help figure out, whether or not to put your patient on technology. So if your patient is struggling to use a smartphone, probably do not put them on technology because they will just struggle, and then I'll have to deal with that later on. Compliance to medications, can they carb count? Pumps do not take out their responsibility to carb count and to dose, despite it's a very common misconception. It takes a little more effort with a pump. If they are not good at missing or taking their insulin, they probably won't be as good on the pump either. although that can actually facilitate things a little bit. There was a study back in 2010 that only showed a 0.3% reduction of A1C with those on a pump versus on multiple daily injections. So the pump is a great tool, but it's just a tool. It still requires a lot of effort from them to control their A1C. And then a few other things: do they like to be connected to tubes versus not tubes? That'll help decide which pump. Also, insurance, unfortunately, is a big part of this. Does insurance cover this? Last few minutes I have here, so I want to talk about obesity medicine. This has been a huge topic. I get this question every single day in my practice. Can you prescribe me this medication I saw on Twitter or I don't do much of the social media, but whatever those are out there now. To give you some statistics, March 2020, 42% of Americans were in the obese or overweight category. This is up almost 12% from early 2000s up to 2017. Obesity is becoming as big of a problem as diabetes, and you can see those correlations together are going up. In terms of annual cost, $173 billion a year in 2019 in the United States. We know that medical costs are increased for obese patients. A few FDA-approved medications that we have for obesity right now, phentermine is probably still the cheapest. It gives good weight loss potential, about 6%. And it does have some side effects, so if they have problems with hypertension, tachycardia, that can make things worse. I do not use orlistat very much. I do not have people that do that very well, and nobody likes to have oily stools all the time. Phentermine topiramate, 8 to 10% reduction. Some of the similar symptoms that are occurring with phentermine, and then you also have to worry about women of reproductive age with birth defects with this medication. I haven't used much with naltrexone bupropion. I will prescribe bupropion when someone has depression and struggling with weight gain. It does help out. It's not as effective in terms of weight reduction, only about 2 to 5%. And then the most popular ones out there right now because of social media, liraglutide and semaglutide. It really is a very good medication, up to 10% weight reduction in these patients. A little bit of hypoglycemia risk in terms of our diabetes patients who may be on insulin. The medication itself does not cause hypoglycemia. But you also have to worry about the risk of pancreatitis and also the medullary thyroid cancer in these patients. I won't go over this slide too much because it's time, but the question about with the medication tirapazide came up with GIP versus GLP-1. It's a little bit more effective, and for some of these reasons that it helps with the additional hormone compared to the GLP-1 agonist. The trial that was performed with this was between tirzepatide and semaglutide. It was an open-label phase 3 trial, 40 weeks, had a lot of patients, 1,900 patients, and they compared 3 doses of this medication to the semaglutide at 1 milligram, and they measured change in A1C, and a secondary outcome was weight reduction. In all 3 doses, tirzepatide outperformed the subcutaneous semaglutide at 1 milligram, just slight improvement in A1C at the 5 milligram versus 1 milligram dose, but you can see there's a little bit of separation and also better weight loss on the higher doses. One thing interesting to note is that between the 10 and 15 milligram doses, there was really not much difference in A1C, so we kind of max out the benefits of that medication at the 10 milligram dose. That's all I have for you today. Thank you for being here.
Are there any questions? Going once, twice? I'm sorry, you can't ask one. Anybody else? Okay, go ahead.
Just a question about PPIs and osteoporosis. Is there a good study?
The mic.
Any information on that?
Did you hear it?
Can you hear me? And the osteoporosis, everybody's on PPIs and everybody is worried about osteoporosis because of it.
Yeah, there is some data out there that shows that PPIs probably decrease bone density to some degree. I haven't come across a lot of those studies yet, but Obviously, I'm kind of a minimalist where if you don't need to have the patient on a PPI, that's going to help improve that. I think it does also have something to do with absorption, but I don't know the exact mechanism behind it.
Okay, and then the other question is, nobody wants to take it because of the jaw necrosis. Do you ever see that?
So I've been in practice for about 7 years now, including my training. I have never seen osteonecrosis of the jaw. It's something that I have to talk to patients on a daily basis when I prescribe this medication. It is such a rare condition. Maybe some of our dental colleagues will say otherwise, but I have not seen it in practice in 7 years, and I've prescribed a lot of bisphosphonates. So.
One more.
I have a question about bisphosphonates. For a while back, I guess they talked about a drug holiday. And so I was wondering, after that 5-year mark, do you just stop it altogether, or do you just keep going? And has that been now refuted with more recent studies?
Yeah, so good question the question is about drug holidays and bisphosphonates. So you definitely want to be aware of how long these patients have been on a bisphosphonate. The longer that they have been on the bisphosphonate, the higher risk for that. The oral bisphosphonates, you're looking at probably about 5 to 8 years where you want to start to consider that. Zoledronic acid, the IV form, would be probably about 3 to 5 years where it's going to start to have that risk. But you always have to take into consideration what is their bone density doing. If it's not improving on that, you need to have them still on treatment and maybe switching classes or going up to the very high risk group medications would probably be the benefit there instead of just continuing on the bisphosphonate.
What's your opinion on surgery for obesity? You have 30 seconds.
Perfect. that could be a whole 30-minute conversation. So I support it. I think there are definitely a lot of evidence and research into bariatric surgeries in terms of weight reduction and also diabetes reversal. So yes, I think it is a very good mechanism. But these patients really need to be educated on some of the risks of that because it's going to drive up the risk for malabsorption syndromes later, hyperparathyroidism. It also will increase the risk for osteoporosis in the future. So I would say go for it. Always start with lifestyle interventions first. Make sure that they are doing what they can diet and exercise-wise before the surgery because the surgery will not change those habits later. And if they eat through the surgery, they're going to be in a lot of trouble later on. And so make sure those practices are there. Have them do the surgery. There's great results and great evidence that shows that supporting that.
Medroxyprogesterone in women's health and bone density. Are there any clear-cut guidelines on how long we can keep someone on medroxyprogesterone? Do we need to do screening? Do we need to have them on vitamin D and calcium?
Good question. The question is about progesterone therapy in women with postmenopausal osteoporosis. So mostly estrogen is the hormone that helps bone density. Progesterone will help a little bit with that. So more important for hormone replacement therapy to be on estrogen therapy. Obviously, if they have an intact uterus, you're going to have to be on progesterone as well. In terms of long-term studies on that, probably about the first 5 to 10 years in the Women's Health Initiative, showed the best benefit for that and the less amount of risk. Once you get to that 5 to 10 year mark, the risk starts to go up for breast cancer and other complications from hormone replacement therapy. But hormone replacement therapy will stabilize bone density. It does not necessarily improve it according to the studies. So trying to get them off in probably 5 to 10 years after initial therapy is probably the recommendation.
Very quickly.
If you had a patient on anabolics and they're not maintaining their bone density after you've taken them off on any of the treatments, can you put them on a different anabolic down the road?
Yes. So far, the data shows that we can put them on a different anabolic. I haven't done this a whole lot yet. I'm fairly young in my career, but as far as I've read and understand that you can switch them from one anabolic to the other as long as there's no contraindications for it.
Thank you, Dr. Brown. I'm sure you can corral him and get more questions answered.